blood test. Liver blood test is a question, and through this test we can differentiate the type of the jaundice or type of the pathology in the liver. So aminotransferases, serum albumin, prothrombin time, and serum bilirubin, main form present. Okay. So bilirubin overload, hemolysis. This aminotransferase is normal, serum albumin is normal, prothrombin time is normal when there is hemolysis. But this unconjugated bilirubin going on increasing. When there will be the increase in the unconjugated bilirubin or the increase in the total bilirubin, but the maximum fraction is the unconjugated bilirubin, then it is mostly a cause of hemolysis. When there is hepatocellular injury, the aminotransferase and the enzymes will be raised, maybe normal or decrease in the advanced stages. Serum albumin will decrease because the liver will synthesize albumin only. When the hepatocellular injury will be there, the albumin level will decrease. Prothrombin time becomes prolonged because there will be decrease in the coagulation factors, mostly A, D, E, K, and different coagulation factors will be decreased. So the the prothrombin time will be prolonged, and the fraction of the conjugated hyperbilirubinemia will be there. The fraction of the conjugated bilirubin will go on increasing. There is cholestasis. Suppose there will be the obstruction of the bile. So this aminotransferase level is normal, serum bilirubin level is normal because liver function is normal. PT is normal because all the functions of livers are normal. But here it is again increase in the conjugated bilirubin levels. So in this way we differentiate between the hemolytic jaundice, hepatocellular jaundice, and the obstructive jaundice. In the obstructive jaundice, the conjugated bilirubin level will rise, but hardly there will be a increase in the serum hepatic enzyme levels like AST, ALT. Mostly the alkaline phosphatase level will rise because it is mostly secretion from the CBD. Rest AST, ALT may be normal or this slightly elevated. But when there is a hepatocellular jaundice, there will be rise in the both conjugated or unconjugated bilirubin along with the increase in the enzymes levels. Low hepatocellular enzyme level will increase, and also there will be coagulation defects like the PTNR level will increase, the coagulation factor will decrease, serum albumin level will also decrease. But hardly the serum albumin level will decrease in the obstructive jaundice. And in hemolytic jaundice, only the unconjugated bilirubin level will increase. Rest of everything will be normal. Alkaline phosphate. Here is normal, here it is normal, here it is increased. Because it is mainly a source from the CBD. GGT, normal, normal, here it is increased. Blood urea nitrogen, normal, normal, normal. So dye, there may be the BSG or ICG dye, that is indocyanin green color dye, very rarely used. It is normal in unconjugated hyperbilirubinemia. There is some retention of the dye, normal or retention of the dye. It is not done right now. By using this type of parameters, GGT level, alkaline phosphatase level, serum albumin level, serum bilirubin level, conjugated and non-conjugated hyperbilirubinemia, we can easily differentiate between the type of the jaundice. Coming to HRS, 5 marks question again. So there will be cirrhosis, there is a hepatic dysfunction of the cirrhosis of the liver, there will be the obstruction to the portal blood flow or the development of the portal hypertension. Once we develop the portal hypertension, increasing shear stress to the splanchnic vessels happens. There will be increase in the production of potential vasodilators. So therefore there will be splanchnic vasodilatations. Once there will be splanchnic vasodilatation, all the bloods will be pulled to the splanchnic circulations. So it will decrease the blood flow to the end organs, mostly to the renal systems. Activation of the vasoconstrictor systems mainly reach to the SNS, RAS, and ABP mechanisms are stimulated. So they decrease the renal hypoperfusion or they decrease the blood supply to the renal system. So there will be activation of renal hypoperfusion, and there is the development of renal failure. Once there will be renal failure, there will be water and sodium retention, and it leads to development of ascites. Sometimes this production of vasodilatation or production of vasodilators will lead to the systemic circulation, and there will be systemic vasodilatations. Again, it will lead to the stimulation of baroreceptors and the activation of vasoconstriction system. So in this way, it develops renal hepatorenal syndrome. Once there is cirrhosis of liver, it will go on increasing the doing the portal hypertensions. Once portal hypertension will be there, it will produce splanchnic vasodilatation and also systemic vasodilatations. Once splanchnic vasodilatation will be there, not a lot of blood will come to the splanchnic circulation, and there will decrease in the renal blood flow or the development of the renal dysfunction because of the decrease in the renal blood flow. Once there will be production of vasodilator in the systemic circulation, there will also hypotension, and they will also stimulate the baroreceptor to increase the systemic vasoconstrictor. In this way, again, there will be decrease in the renal blood flow, and finally, the patient is going to the renal failure. This is the whole pathophysiology behind the hepatorenal syndrome. Coming to the DNB questions. So the child pox criteria is a question, and how it is relevant to the anesthesia, we have already read. Hepatorenal syndrome, criteria, type 1, type 2, type 3, type 4, treatment protocols. Management of hepatorenal syndrome in obstetric jaundice, again, same thing. Modified childpox course, anesthesia importance. See how the questions are repeating. Hepatopulmonary syndrome, see the questions are repeating. Hepatorenal syndrome, one question. Hepatopulmonary syndrome, another question. 40 years old patient in the OT for CVD exploration with severe hyperbilirubinemia. What are the anesthesia importance? Hyperbilirubinemia. So here we can write pre-op, intra-op and post-op again. The hepatic dysfunction may be there, so coagulation function, PTINR, everything should be measured. Again, the drug, same thing. Hepatic metabolism is impaired, so we go for this cisatracurium, atracurium, isoflurane, desflurane, propofol, intermediate. We'll avoid becuronium. These things should be written. Pathophysiology of jaundice, we have already discussed how it is breakdown. The heme is breakdown from bilirubin, unconjugated bilirubin, conjugated bilirubin, go to the intestine, stercobilirubin, excrete in feces, enter into the enterohepatic circulation. Here the unconjugated bilirubin will go to the renal system as because it is water soluble. Portopulmonary hypertension, we have already read what are the features and what are the criteria. Pulmonary vascular resistance more than 240, pulmonary arterial pressure more than 25, pulmonary arterial oxygen pressure less than 15. So these are the criteria. The treatment, everything we have done. And hepatic phase of the liver transplant, I already told only a single phase of the hepatic transplant they will ask for the 5 marks questions. You will write what are the surgical steps there and what are the anesthesia consideration there, how to prevent this. Simple. Describe hepatorenal syndrome, again diagnosis and management. Describe diagnosis and management. So long question, but 5 marks you have to write. Discuss hepatorenal syndrome. See how many times it is repeated. Hepatorenal syndrome, hepatorenal syndrome, hepatorenal. So how much it is input. HRS you have to read, you have to read, you have to read. It will definitely come in exam. Discuss the blood supply of the liver. The role of liver in the maintenance of normal coagulation. So vitamin A, D, AKA again. So this is all the clotting factors except the factor of 1 million factor and factor 8. This thing you have to write in exam. Blood supply of liver, portal vein, hepatic arteries. 85% through the portal vein, 20 to 25% through hepatic arteries. So these are the explanations to these different questions. Mostly we have solved all the DNB questions in the previous 5 years or 7 years, and hardly any question outside it will come. But again, you have to read elaborately liver because laparoscopic cholecystectomy is a favorite question. It will maximum time it come in exam. Cirrhosis of liver, ascites, they will causes a short case. Maybe ask about hepatopulmonary syndrome, hepatorenal syndrome. Outside topics they will definitely ask. They will also ask about the pathophysiology and the metabolism of the bilirubin. So therefore this everything should be kept in mind. Here little bit pharmacology they have also gone asking, and little bit about that pharmacokinetics of the drug, how it is hampered, which drugs are binding to the serum albumin, what is volume of distribution. They will definitely go on asking all these questions. So please read physiology and pharmacology properly when you are getting a case of liver. Thank you.